First debate session is the primary treatment for newly diagnosed glaucoma. And supporting the use of SLT in this context is Dr. Poemen Chan, Assistant Professor in the Department of Ophthalmology and Visual Sciences, the Chinese University of Hong Kong. So Dr. Chan graduated from the University of Hong Kong with multiple scholarships and awards, and he's the coordinator of the CUHK, HKEH, and PWH International Fellowship Program, as well as the academic coordinator of the Glaucoma Service of Hong Kong Eye Hospital. He has also served on various committees in the World Glaucoma Association, the APAO, as well as ARVO Asia. So let's welcome Dr. Chan to give his talk. Poemen, please.
Thank you very much for the kind introduction, Shelvin. So can you see my slides?
Yes,
so.
Yes.
Right, so thank you. So I'm Poemen Chan from Hong Kong, and thank you very much for having me. I'm in favor of doing SLT as a primary treatment for newly diagnosed glaucoma, and these are my financial disclosure. Now, of course, we're talking about primary open-angle glaucoma here, and this is the usual kind of intervention algorithm of primary angle glaucoma. You go from medication, followed by laser, followed by surgery. This is logical because it is a less invasive to more invasive procedure. However, things are changing with the advancing technology and also new evidence. I mean, we'll talk about that. Now, the severity of glaucoma is also a concern, and we have to think about that when we are talking about which treatment to pick. Let us also remind ourselves that the purpose of glaucoma treatment is to prevent disease progression and also maintain or improve the patient quality of life. It's not just about lowering the intraocular pressure, so that's important. Now, SLT, as we know, is an office procedure, and it's targeting the trabecular meshwork that hopefully would increase the cytokines-mediated change of the Schirm's canal cells permeability and also directly induce the intercellular junctional disassembly in the TM. The serious side effects are rare, they are known, but they are usually resolved with conservative treatment. As you can see in this electronic microscope, after SLT, there's minimal disturbance to the structure, if any at all, after the SLT. And this is one of the rationale why we can repeat SLT for another time. Now, for the light trial, I'm sure you all know, is groundbreaking and is actually changing our thoughts about primary treatment. So they actually suggest that SLT should be offered as a primary treatment, as a first-line treatment for open-angle glaucoma and ocular hypertension. And it also shows that there's a reduction in use of medication. Now, this is what happened in the light trials. They randomized patients into two groups, those who are treated with SLT first, or patients who are offered medication first. Now, they followed the patient up for 3 years with an adjustable target intraocular pressure and also intensive follow-up. And the peculiar thing about the light trial, which makes them so great, is that they evaluate the patient according to the quality of life as their outcomes measures. So for primary outcome, the health-related quality of life has shown no difference between the two groups. However, for the glaucoma-specific health-related quality of life, the SLT group actually show a better health-related quality of life outcomes. Concerning the effectiveness, SLT group demonstrated good achievement of target intraocular pressure without medication or with medications. Only about 60% of patients, well, 60% actually patients actually only had one single laser. And the drop-free rate in 3 years is 74%. So that is actually very high, higher than what we expect, of course, because of the different protocol that they're using. Now, for the as far as the treatment escalation and disease progression is concerned, the need for treatment escalation, disease progression, cataract extraction, and also the need for trabeculectomy, the rate of in the SLT group are all lower, were lower than the eye drops group. Talking about safety, there's no sight-threatening complication in the SLT group. 34% of SLT group actually reported transient discomfort, but overall, the systemic and serious adverse events are similar for both groups. Now, the implication is that it shows that initial SLT is effective. It shows a better intraocular pressure control, low rate of disease deterioration, and also low rate of surgery. It's safe and it's potentially cost-effective as well. And as I said, 74% of patients had drop-free period for at least 3 years, and the requirement for intensive medication or surgery might be deferred or completely averted by SLT. Follow-up studies of the light trial also show favorable results. The repeated SLT can maintain IOP at or below target IOP in medication-naive OAG, and also ocular hypertension eyes. There's a slightly larger proportion of ocular hypertension, hypertensive, and also glaucoma patients treated first with medication therapy underwent rapid visual field progression compared with those treated first with SLT. Now, I'm pro SLT, but then we have to be very careful when we are considering patients for SLT. Notice that this is the demographics of this baseline of the patient in the light trial. As you can see, actually less than 20% of the patients were moderate to severe ocular OAG patients. Most patients were in the categories of ocular hypertension or mild open-angle glaucoma, according to the Canadian Target IOP workshop, which defines the different categories of glaucoma according to the mean deviation and also the involvement of central scotoma on visual field. So now 30% of patients were ocular hypertension. And if you look at ocular hypertension, going back to the OAK study, in 5 years' time, if you don't treat the patients with medication, 9.5% of the untreated patients have glaucoma versus 4.4% for those who are treated. So you're talking about apparently a very good response. You're talking about a reduction of the risk of having glaucoma by half. But then it also means that the number to treat to prevent one glaucoma is 20. So it is not cost-effective to treat all patients with ocular hypertension. The recently published data shows that in 20 years follow-up, only approximately 25% develop visual field loss in either eye. So there are rooms affordable for monitoring, and perhaps doing a SLT for the patient is a safe way to go. Now, the eye-specific target IOP that is specific in the light trial also show that is very sophisticated in terms of how they target the patients for different target IOP. So different categories of glaucoma or ocular hypertension, they have their own target at baseline, and that happens to be adjustable as time goes along. So if the IOP, so they have to be monitored rather intensively, and if the IOP is above the target by less than 4 millimeters and that show no progressions, they can escalate the target IOP. So the success rate of SLT is affected because of the target IOP is adjustable, and that's explained why the rate of success is so high. So an intensive follow-up is required, and if we are not monitoring the patients in real life situations, something that's a situation that you might not be able to do that many follow-up for the patients as you could in the light trial, you usually target an intraocular pressure of more than 20% or equal to 20% reduction from baseline. And with that as your target, you're talking about a 27% success rate in 2 years. So that is not very high. And that means that if you're using that as a target, you are dealing with patients that repeated procedure afterward. Now, talking about the corresponding health utilities for each categories, you notice that this is the health utility. So range from 1 to 0 for the score. So 1 is perfect health, and 0 means death. So for ocular hypertension with no visual field defect, the health utilities, of course, full marks. For patients with early or moderate glaucoma, at most, you're talking about a reduction of 10% of the perfect health utility down to 0.9. Now, what does that mean? That means that the patient is affected, but if you think about the medication side effect, it also could be quite devastating for our patients. Study has shown that quality of life and utility loss as a result of severe side effect from glaucoma medication is comparable to that resulting from a decrease in 10 decibel in mean deviation. So you talk about health utility loss equivalent to moderate glaucoma for patients with mild or even ocular hypertension. And compliance is also an issue. Patient may not be able to get the drops into the eye, and also they miss the drops. They might apply more drops before they come to you, just to make sure that they get a good result. Some people talked about medication as a reminder for them to come back for follow-up, because if they do the laser, they forget about their disease and they don't come back for follow-up because they think they're fine. But I think this is a price too much to pay, given the kind of side effects of the medication that we have for topical medication. And of course, as I said, the cohort in the light trial, less than 20% were moderate to severe glaucoma. So we need further studies, such as the next study, to tell us what to do as a primary treatment for more severe glaucoma patients. So this usual logical algorithm of medication to laser to surgery might need to be revised. I am in favor of the SLT. I think medications do have the problem. I'm not saying that I'm not entirely against it, but laser, the SLT should be considered very strongly as a primary treatment for glaucoma. Thank you very much for your kind attention.